The broadcast is now starting. All attendees are in listen-only mode.
Good, thank you. Yeah, so once again, this is the webinar from University of Texas and the Texas Cares Project. It's also brought to you by the Science Teachers Association of Texas, STAT. So they've participated in this project. So we'll get going in just a couple minutes. We have a pretty full agenda, so I think we'll start in 2 minutes. Welcome again, everyone. My name is Steve Kelder, and I think let's get the show on the road, okay? First of all, I need to tell you that I am in Waco, Texas at the moment. I drove from Austin to Dallas to drop my son off at University of Texas, Dallas, and because of all the heavy rain that's been going on the whole way there and back, I didn't make it home in time. So here I am at Panera Bread. So please excuse me if there's doorbells ringing and a little bit of music in the background. I'm just going to talk for a little while, and then I can mute myself later when Dr. Cole, Dr. Delclos come on board. So again, thank you for being here. Today we're going to talk a bit about schools and some of the more current things which are happening with COVID, about restarting schools, some of the announcements by the CDC. We're also going to talk about a study that's called the Texas Cares study. And it's one where we're collecting data to try and answer specific questions about what's going on in Texas. Dr. Cole's going to talk about that. And then at the end, we've got Dr. Delclos, who's going to help us understand more what are some of the physical features and safety matters and side effects related to the COVID vaccine. So next slide, please. Here's our speakers, and you can see on the right what we're going to talk about. It's a good bunch of people. We're all at the University of Texas School of Public Health in Houston, and we're all faculty in epidemiology, human genetics, and environmental sciences. Next, please. And again, I just want to say thank you to the Science Teachers Association of Texas. I stole this from your website. That's the only logo I could find, to be honest. But anyway, thank you very much. We've been collaborating together, and they help sponsor this webinar. Next, please. So I just want to start by mentioning, in case you don't know, that there's two different things that we're considering. Look on the left, there's the viral test, and that's to detect whether you have a current COVID infection. Then there's an antibody test. And what it does is it can tell whether you've ever had COVID. It can, Some tests can also detect antibodies that comes from the vaccination, but there's more specific tests that actually can do that rather well. So they can tell whether or not you have antibodies in your blood because of having the previous version of COVID or previous COVID infection, and one from the vaccine, which is what's intended by the vaccine. So we'll talk more about that. Dr. Delclos will, but just to orient everyone to these two different major features of COVID, and the studies that we're doing. Next, please. So I want to start again by talking about schools. So this is from a CDC, and if you Google this, K through 12 schools, COVID mitigation, and the toolkit, you'll find lots and lots of information. The last few days I've been reading this website, and there's a number of mitigation strategies. You probably know a lot of it if you're working in a school. I'm sure you know most of it. But the reason why you want to go back to this site is because the CDC is constantly updating their toolkits so that you can better understand what's happening. Next slide. So you heard recently from the CDC that when you've been fully vaccinated, you can do things. You can resume regular activities that you did prior to the pandemic. If you're fully vaccinated, you can, without wearing a mask or physically distancing, except as where required by federal, state, local, tribal, and territorial rules and regulations, local businesses and workplaces. And this is, I cut this right off of the CDC website. If you haven't been vaccinated, we're suggesting that you do so. Now, when we talk about schools, we only just the last week started with making available the 12 through 15 vaccine. Again, Dr. Delclos will talk more about that. But it's important to note that not many kids yet are vaccinated. And probably the most important thing in this whole webinar in the next hour that you'll learn is that it would be a great idea to encourage parents to have their kids vaccinated. And the major way of doing that is going to your pediatrician or family practice doc, general practitioner, whoever you see with your children, then ask them about the vaccine, and they can make judgments on individual cases and such. But so that's probably the most important thing to know for the fall, is that the vaccine is coming. It's here. There are announcements that they're working very diligently on the even younger age vaccine. So that possibly could be here next mid-fall. So I can't say with any confidence, but they say that the trials are going very, very well. Next, please. So in reading many, many different sources of information, I finally came to the conclusion that cooperation is the only way to end the pandemic. And that starts with getting the vaccine. I know there's some folks that don't feel quite ready to do it. That's fine. I do wish that you would consider it and learn more about it. Visit your health practitioners and learn from them. If we get the population vaccinated, then we can feel more comfortable about resuming normal activities, just as the CDC said. But again, the caveat is that not all kids have been vaccinated. In fact, they just started it last week. So George will cover things, but the COVID vaccines are safe and they are effective. Once you're fully vaccinated, you can start doing the things you stopped during the pandemic. And at this point in time, I must say that the Texas Department of State Health Services, who gets to make the call about requiring the COVID vaccine in schools, has not done so. And in speaking to some of their liaisons just recently, they do not intend to make vaccines a requirement for school next year. So that situation could change, but they said they don't have any plans for it, so I don't think it will. Next slide, please. So how do you decide how serious you need to take your precaution efforts? And just like over the past year, looking at the rates in your community is the best way to do it. So CDC, I cut these out from CDC again. First of all, if you see the blue, yellow, orange, and red indicators, that's the local community background rate. So in the blue and the yellow, you can relax a little bit, and then in the green and the red, you need to pay a little bit more attention to it. So CDC is still saying that schools should deploy these 5 key prevention strategies: universal and correct masking, some level of physical distancing. In most circumstances, it's 3 feet. I think they've dropped to 6 feet for schools, so 3 feet. And then hand washing, of course, respiratory etiquette, teaching the kids to cough and sneeze into their shirt, and then maintaining clean and healthy facilities, and getting involved in the contact tracing or combination with isolation and quarantine. So there's guidance on isolation and quarantine. They start with trying to understand the symptoms. So I cut this poster out so you can better understand it. Next slide. So how do you know what's going on in your community? There's a number of different places to go. I've listed 2 here on the left-hand side. It came from the CDC. And there's a map of the United States at the county level. So you can click on any state and zoom in on any county. So that's how you can tell, at least at the county level. They do have some communities, but they're probably, the larger communities because of their population density. So here you can see maps that you can collect and see different things. So one is just how many cases, how many deaths, how many hospitalizations, and so on in your community. So I would recommend that a school district at least have one person who looks at this on a regular basis, maybe more. So your health officer, if you're a larger district, principals. On the right-hand side is a related but different form of information. It's from the University of Texas in Austin and their COVID preparedness center. So they're going to provide by many different communities throughout Texas. I think they have 50 or 60. Yours may or may not be in there. I don't control which ones they look up, but you can get the local Texas data. And here you can see the tail on the right-hand side. So that's the daily COVID. And then on the bottom, sorry, my screen is, the ICU visits. So they're trailing off too. So those are indicators of a nice progress, to be honest. So we do appear to be turning the corner, or have turned the corner on COVID as resulting by this, but we still recommend these safety precautions for schools and for kids, and again, taking them more or less seriously based on the local community rate. So look at these places, CDC or the UT Austin, and you can gather information about your community and know how much effort to put into preparation for next school year. Next, please. So now I want to switch gears a little bit. We're going to learn about the Texas Cares project in just a minute, but we've been doing this for almost a year now, this project, and basically we're looking at data that relates to antibodies, and I'll tell you more about it in just a second. But in talking to schools and school districts and the Staff Association, Nurses Association, etc., what we decided to do, and we got 3 different science teachers here in Texas to help us build up a set of lessons. So we have grade bands at K through 2, 3 through 5, 6 through 8, and 9 through 12, and we're offering information that you can share with your students so that they can get a better understanding about what's happening with COVID. So this has been vetted through our virologists and other folks. So we feel pretty good about them. In fact, we just got them done and just got them up on the web. Next slide, please. So just want to show you what the website looks like in the classroom. If you click on any of these on the bottom left-hand side, it'll take you into the grade level materials, or you can go directly into it through the right-hand side, the Texas Cares curriculum page. And by the way, if you don't have time to take notes on all these things, this will be posted on the website soon afterwards, and you'll be getting, if you're a registered person, you'll be getting a copy of this so you can visit it and excuse me, and where to find it on the web. Next slide, please. So just to show you, dig a little bit deeper on the right-hand side, once you get into the overall lesson plans, you can, again, click on the grade bands and find out what's going on. Next slide. And this just shows a sampling of what's available through the lessons. We use the 5E orientation to create the plans and all of them. And we also, on the right-hand side, you can see that there are some exercises to explore what is on our online dashboard for the Texas Cares project. Next slide. So if you could play this, just for something a little bit different. This is in our media toolkit. Oops, I am not hearing the sound.
I may need to unmute my...
That's okay, just let it play through. We don't have a lot of time to spend on this little bit. Just imagine some funky music playing. So these are two guys that are local to Texas that are influencers, social media influencers. So we're trying to help people understand about that knowledge is the superpower. So we have a whole social media campaign surrounded about that. Excuse me. The stat group has been nice enough to give us a location on their website to be able to access our media materials that you can send to your teachers or other folk and let them know about the study. So the little video is just a way to gain attention, but the project itself is funded by the Texas Department of State Health Services through the UTHealth School of Public Health. It offers 3 free antibody tests, and the reason we're doing those is to help learn more about exposure in our community, about how long COVID-19 antibodies last, and how much protection they provide. You know, if you're looking at the news, there's often conflicting understanding. So that's why we want to be able to do this study and share it back to the citizens of Texas. And we will update it through a dashboard that you're going to see in just a few minutes. Next slide, please. So Texans age 5 to 80 are eligible to participate, regardless of their vaccination status. You know, when we started this project a year ago, we didn't worry about vaccination status, but now that so many people have it, I just want everyone to know, those who were previously in the study or those who are new to the study and just signing up for their first blood draw. We are now able to tell the difference between the natural occurring antibodies by getting the COVID disease and the vaccine. Next slide. So there's 3 main questions we're trying to answer. So we want to look at vaccine-induced immune response. We want to look at pre-vaccination immune status. And then look at recent or prior COVID infection in relation to vaccine status and your immune response. It is still not completely well known about if you get COVID, how long that it will last, the immunity status, that is. So we can measure that by taking the blood draws, and that's why we're taking it 3 times over a 6-month, maybe a 6 to 9 month period. So we'll look at your first value and then see how things have changed, and you'll do a questionnaire, and that'll help us understand how things are situated. Next slide, please. So here's the process. You just go to the Texas Cares UTHealth website. We'll tell you about the study, as you can see on the left-hand side, and then we'll ask for your permission to give you a questionnaire. and it's a brief survey. So that's step one. Next slide. So once you're in and through with the questionnaire, we'll send you to a different website at CPL Labs, Clinical Pathology Laboratories. They're located all over the state. So you can just find the nearest one, and you can just walk in after you've registered with the study and taken the questionnaire. You'll be in their database. So they'll be waiting for you to come and get your blood drawn. Next slide. After you get your blood drawn, 2 to 3 days later, you'll get a text, and they'll tell you whether or not you are showing antibodies for the COVID-19. Next slide. And then you'll receive future text messages for your second and your third administration of the blood test, so that then you can see how things are changing over time. Next slide. So we've heard some really nice things from our partners. Sometimes we'll do it at school districts. Sometimes we'll do it at local universities. We'll have big community events. We had a big one in Houston at Goose Creek ISD, and they opened up their community center and allowed us to do this. We'll set up a couple stations, take the blood draw, and then get you going real fast. Or you can go straight to the CPL labs, which again are located all over the state. Once you fill out the questionnaire, you'll be taken to a map that'll show you where they are. And you can click and see if they're nearby you and their hours of operation, etc. Next slide. So just a little bit of our social media. I'm about to switch gears and pass it to Dr. Cole, who's going to talk some about the results of what we found so far. Next slide. Okay, Bill, take it away.
Hello to all. I'm here. This is Science Teachers Association. I thought we ought to talk a little bit of science. One of the cornerstones, one of the fundamentals of public health is epidemiology, and a cornerstone of epidemiology is surveillance, meaning that if you're an epidemiologist, you like to count things. It's straightforward usually, but in rapidly developing situations, we have with figuring out how to count things, figuring out how to implement this particular survey is quite challenging. And I'm here making the presentation of some of our early data today. I have to acknowledge all of our co-investors in Brown and places throughout the state who are helping us develop this aspect. One of the keys that is tied, as Steve talked about, is tied that the brand the K-12 curriculum is data. The data that we are collecting are anchor lots of the lessons that make up the K-12 curriculum. So those of you who might be interested in developing these lessons and lesson plans for your use, are anchored very well in the data that we're collecting. There are a couple things that we've been able to do in the last year, and I claim no skills at this, but our data analysis people in Houston really moved this. There's a real-time dashboard that is available. I believe the link has been put on. It's been put that allows you to click on it. But there's a dashboard for Texas Cares that gives real-time data associated with everything we're trying to do as part of the Texas Cares project. I put a screenshot up here and we'll talk about it, but it's things rapidly that we need access to real-time data. 6 months and be able just to data without having services and others to make it possible to alter courses and key decisions in the best interest of public health without these dashboard and without real-time data. So it's a big step forward in terms of disease surveillance, and it has applications on what we're doing here as part of CARES. Pleased to share some of today, particularly as it relates to people in one of our priority areas, which is in the field of education, and as well as children. We started off early in the process last summer and made sure that we emphasized recruiting people, teachers, support staff, and others who are on the front in schools, as well as children in pediatric clinics around the state, so that we can get a better handle on what's going on with antibody response. Our children's sample, our pediatric sample, is the largest in the world right now. It allows us to estimate what's going on with kids. So let's take a look a little bit. Next slide. Right now, looking at about 9,400 people around the state who have signed up, from the way to Del Rio and line all the way to Angle, if you will. It's all over the state. What a global antibody response to natural immunity, meaning there is some evidence that people who have had their blood drawn have a response to the virus that causes COVID-19, and it's about a quarter of the population in general. Here, next slide, please. I've highlighted particularly our educational professionals, which percent of the. Oh, can you go back, please, to emphasize those two pieces of data? Thank you. 24% of the educational was just over 600 positive for natural antibodies, and interestingly, in Houston, in leading this effort, but more than a third, almost a third of school-age children being shown antibody response, and that's a bit puzzling because there's things in the literature that kids have fewer symptoms, and the symptoms they do have may be less serious. So a conundrum of on with this this we have, but these are the numbers we have. 30% appears to have a baseline patient, appears to have an NOV2. Next slide, please. And here there's the younger age groups highlighted there, all the way to the older age. 32.4% for kids less than 10, all the way to 16.4 as the low adults over the age of 30. Remember, this is a voluntary sample. This is not a random sample, but have elected to come in and participate in the study and transfer the CPL for blood draws. So it's not in the state of Texas, but it is a large population-based sample. sorting there's no differences between men and women, it appears. People of Hispanic ethnicity versus non-Hispanic, roughly the same. No dramatic differences there until you get down to race differences, where we see an outlier of people who identify as American Indian, Alaska, Hawaiian, or other Pacific Islander. Only nearly 6% are reporting or are showing antibodies, positive antibodies. The remainder of the racial groups are all above 20%. That is a low number of participants, but it is something that is worth investigating as we go forward. Next slide, please. One of the nice dashboard allows us to do is plot real-time changes and allows for interpretation over time. This is the overall sample with different priority populations highlighted in different colors. And I wanted to emphasize the education is in is the orange line. It's not moving for me. Next slide. There we go. There, those people identifying as educational professionals. And you can see from September all the way through this last few weeks, what the in this peak moving average is for seropositivity. And you can see as prior to the vaccine used in late December, early January, we were around 20–25%. As more people got tested, again, this isn't vaccine-induced immunity; it's natural immunity. We ended up ending at 5%, and then as fewer people got tested, and as hopefully the number of infections is declining, positivity percentages have flattened out and are starting to go down here. Features that put the similar curve for a pediatric population that we're making. You can't have educational professionals without children in school, and the purple line up. And you can see kind of a trajectory starting for kids in our particular survey, similar trajectory that peak in and leveled off and is now starting to decline over time back in. But the peak here was unexpected in this area. For several weeks, more than 40% of kids who were tested were SARS-CoV-2 antibodies. Next slide, please. And just Steve mentioned these new data. Sound is choppy. I turn my video off and bandwidth. So anyway, watching as Steve pointed out, this is a three time period. So people at baseline, 3 months later, and then 3 months after that. So for a 6 period of time, we're back and get retested. So the question that allows us to estimate is among antibodies, how long do they last? If people come back in 3 months and 6 months, are the antibodies around? And this is one of the first looks as we started to accumulate people who've been twice, and now some smaller percentage have come back. What I've done here is I'm one at their across the bottom who tested positive to tested negative, and at back percentage of people at time 2 positive and negative. So the way to read this is among those who tested positive at time less than or 1.1% actually were 2. That is in fact a screening test, and so there is some error involved. It's also a continuum, several maybe just under the cut point to be declared positive. All the population that was positive at time 1, 3 months or approximately 3 months, remained as positive at time 2. If you take a look at those who were negative at time 1, and then those who were negative again at time 2, nearly 90%. These are the are there. So these are the 2 squares that you want to post the highest proportion of people in, and in fact that's what the data are starting to show now, that who were positive, tested positive at time 1, also the vast majority tested at time 2, meaning those antibodies were still, and then those who were negative also, the vast majority also tested negative at time 2. And to put an emphasis on the next slide, we'll show the medication professionals, the subset of people that are of the group that we're in, for teachers and administrators and so forth. But the data are virtually the same. Next slide, please. Antibodies, there we go. Education, people who tested positive remains over time. So these are early look at these data. The opportunity in not patient professionals, but overall remains, and start to get closer to time 3 and get more data for time to further elucidate that. Again, these are on the dashboard. Hopefully you make liberal use of them to help teach your students about SARS-CoV-2, about proportions, rates, all kinds of different things are in the lesson plans that can help you. I'll turn this over to Dr. Update on vaccines now.
Thank you, Bill. Before I start though, Jessica, just wanted to do a sound check. Can you all hear me okay?
Yeah, you sound nice.
Yes, I hear you quite well.
Okay. Oh, thanks, Steve. All right. Well, thank you for inviting me as well. You know, we've been hearing a lot about vaccines for the last several months. So I'm not going to go through all of the details. I'm going to try instead to focus on some of the issues that remain a factor in the level of vaccine hesitancy that we have. You know, overall, we've been doing pretty good. I mean, we started off slow, but then we've really taken off. And, you know, proof of that is the, as Steve was presenting, have been the loosening of masking guidelines by CDC in certain environments. But at the same time, there's increasing concern that the remaining group of unvaccinated folks, what we call the vaccine hesitant folks, is large enough that may prevent us from getting to what we wanted to get to, which was called the famous herd immunity, which is estimated to be around anywhere from 70 to 85% of the U.S. population being vaccinated. And so when we look at some of the reasons why people are hesitant, it's a very heterogeneous group. Not everybody that's hesitant to be vaccinated is necessarily opposed to all vaccines. In fact, that is probably a minority, a significant minority though. But there are other folks who have various concerns. Many of them are worried that things have gone too quickly. We're not going to address that today, other than just to let you all that even though the process from the development of the first prototype of the vaccine back in March, April of last year, until it got into the first arm of a U.S. Community member in December 15th, was quick, that was not at the expense of sacrificing safety or efficacy data. It was there were several other things that were done that compressed the time and the ability to get this out. But this technology has been out there for quite a while. So that's one of the concerns, that it was done too quickly. Another one of the concerns, and what I'm going to spend a little bit of time on, is whether or not they are safe for adults. And now, having expanded the age eligibility to 12-year-olds to 15-year-olds, this is a big a concern. So I just want to make some highlights or address some highlights about safety and efficacy, so that as you are considering it for yourselves, or as you are teaching this, that you get you keep in mind that the basic points. So next slide. As we know, in the United States, next slide, yeah, there are 3 vaccines that are currently authorized. Authorized means that they are under what's called an emergency use authorization by the U.S. Food and Drug Administration. And this is one of the issues that, for example, some vaccine hesitant folks are concerned about. Previous slide, please. That some of the vaccine hesitant folks are concerned about, that none of these vaccines has been fully approved by the FDA. And that's because the FDA has a mechanism when there is a national emergency, and I think we can all agree that the pandemic is not only a national but a global emergency, then FDA has mechanisms for authorizing the use of a medication with restrictions to address that emergency. The full approval process continues but takes longer. So the 3 vaccines that we have now, Pfizer, Moderna, and Johnson, have all gone through this emergency use authorization, which means 2 things. They have proven that they are efficacious, and they have been proven to be safe. By efficacious, what we mean is that they are actually highly effective at preventing COVID infection if you are vaccinated. In the case of Moderna and Pfizer, what we call our mRNA vaccines, we're talking about 95% effective in doing that. And Johnson is a little bit less, 77%, at preventing all COVID infection. But what's more important about these vaccines is that all 3 of them are nearly 100% effective at preventing what really matters, which is getting severe COVID, the type that lands you in a hospital or 6 feet underground, dead. Almost 100% effective. That's what's most important. So efficacy has been demonstrated. But let's talk a little bit about safety. Next slide, because that's one of the reasons that some folks are still vaccine hesitant. When we talk about safety of a vaccine, we're worried about, or we have to break this up into 2 sets of issues. One are what I call common side effects, or I would actually prefer to call them discomfort. It's not to downplay it, but it is to separate it from what we call severe adverse reactions. The common side effects can either be local, right at the time or shortly after you get the shot, mainly in the arm, or they can be generalized. And I think by now most of the population has heard about these, but the local reactions are typically, and they can occur within a few hours of getting a shot, or maybe after the 2nd dose only, but they tend to be on the arm of the side that received the injection. We're talking about there may be some pain, there may be some redness, there may be some swelling. This is the result of the vaccine doing what it's supposed to do, which is to get the body to start cranking out defenses or antibodies to protect us from infection. And overwhelmingly, these local reactions can be managed at home simply by just settling down, not getting nervous, and applying things like a cold compress, humid compress, moving your arm, or maybe even taking some acetaminophen or Tylenol. And within 24 to 48 hours, they resolve. There are also some generalized discomforts or side effects, if you will: fatigue, headache, muscle ache, chills, fever, nausea. Some of these can be pretty mind-blowing. I mean, you may be very, very tired the next day after a vaccination, but it resolves within 24 to 48 hours. And again, this is not a manifestation of harm to the body, but quite the contrary. The vaccine is doing what it's supposed to do. It's just that some people feel it more than others. And here the treatment, if you call your doctor, probably they're going to tell you, just take it easy. If you have to take a day off from work because you feel that miserable that you can't go, then take off the day off, drink fluids, get some rest, take some Tylenol, and it will be going away in 24 to 48 hours. These side effects and discomfort, when you look collectively at the 3 vaccines, are not uncommon. They occur in about 60 to 80% of people who receive the currently authorized vaccine, but they go away in 24 to 48 hours. That's in contrast to, the next slide, please, what we call anaphylaxis. Anaphylaxis is a severe allergic reaction to one or more components of the vaccines that are currently authorized. If not handled properly, anaphylaxis can be very frightening, could even be dangerous, but it is treatable. It is treatable immediately. And that's why all vaccine providers, at least in Texas, must show the ability to recognize this reaction and to treat it immediately. And so far, to my knowledge, in Texas, nobody has died from an anaphylactic reaction. There have been some, but they've all been treated. One of the reasons, next slide, one of the reasons that after you get vaccinated, we ask you to stay around and watch you, for the majority of people, for about 15 minutes, but people who may have had other allergies to other things in the past, maybe a little bit longer, 30 minutes, perhaps a little bit longer, to make sure they're okay before they go home. The reason is because 95% of these anaphylactic reactions will occur typically within 10 minutes of having administered the dose. So if you're going to have this unusual severe adverse reaction, you want to have it in a place where something can be done about it immediately. And it's treated with adrenaline, with epinephrine, and typically they may take you to an emergency room and watch you. But let's see how common this is. Next slide. So, anaphylaxis, right? So this has occurred. There have been some cases. Remember, we've vaccinated, we've administered well over, we're very close to around the 200 million mark, even more than that. And the average occurrence of one of these reactions is about 3 to 6 cases per million doses given of Pfizer, Moderna, and probably even less with the Janssen, also known as Johnson & Johnson vaccine. Now, other vaccines can also cause anaphylaxis. Pretty much any vaccine of childhood can cause it. In all of them, it's a rare occurrence. It's something that needs to be identified properly and treated, but it's a rare occurrence. Flu shots can give you an anaphylactic reaction. A little bit less common than with the COVID-19 vaccines, about 1 to 2 per million, but still in the range of very, very rare. Next slide. Now, we've also heard in recent weeks that shortly after the Johnson & Johnson vaccine was rolled out, was authorized toward the end of February, in about mid-April, after about a month and a half, not quite, the CDC all of a sudden hit the brakes and said, we're going to put this on pause because we have had a handful of cases of a condition called thrombosis with thrombocytopenia syndrome. Basically, they're talking about blood clots. Blood clots that are typically also associated with another abnormality in blood called a low platelet count. I'm going to keep it simple. Blood clots are not a good thing to have, and they can be treated, but they need to be identified promptly. And it is true that when CDC hit the brakes, put it on pause, they did not remove the authorization or anything like that. They just put it on pause in order to buy time to look at the data more carefully. At the time that they put it on pause, after approximately 7 to 7.5 million doses of Johnson & Johnson had been administered, there were 6 cases And that's what led the CDC to pause and go back and look at all the data. It took them about a week. And in total, they identified about 15 of these cases at the time, and they found some common characteristics. Typically, this did not happen immediately at the time that you get the shot, but within a few days, between 6 and 15 days after you got your dose. Next slide. Predominantly, these occurred in women, and particularly women between the ages of 18 and under 50. Because over 50, it's unusual, even in women. But these rare cases occurred in women predominantly between the ages of 18 and 50. And because of that, they had to weigh the risk of this unusual occurrence, but serious occurrence, against the benefit of the vaccine. And so after about a week, they came back and they said, okay, we've looked at it. We think that the benefits of this vaccine greatly outweigh the potential risks. So we're going to remove the pause. Next slide. We're going to remove the pause. So they did about 10 days later. And they said, we're still going to recommend it, just like it was before for people 18 and over. The only thing is that we're adding to a fact sheet, and we're letting providers know that some women, that this may occur rarely in women under the ages of 50. And so that fact needs to be known by anybody that's receiving the vaccine, just like we need to know about all the other stuff I talked about, the discomfort, the severe allergic reaction, etc. And so that's where we are. When you think about these clots, and I do know that that caused a lot of concern, especially in women. Next slide. You need to bear something in mind. Clots can happen with the Johnson & Johnson or similar vaccine. This is from a study that was published just a few weeks ago at Oxford from Europe. So they didn't have the Johnson & Johnson vaccine, but they had a very similar type of vaccine, which is the previous slide, please. The Oxford AstraZeneca, which is the last one on the bottom. If you'll notice, what we are seeing here, the number of clotting events per million people over a 2-week period of time after their last dose. And all of these vaccines, the mRNA vaccines and AstraZeneca, and presumably Johnson & Johnson as well, have a low risk, but definite risk of causing this. But one thing people shouldn't forget is that the risk of developing clots because you have COVID infection, not vaccination, is much, much greater, because approximately 30% of the cases of serious COVID, the ones that wind up in the hospital or in the ICU, have clots. The actual virus causes clotting at a much higher rate and with much more severe consequences. So keep that in mind. Everything is a comparative risk. Next slide. The second question and final question I'd like to address, I want to move on and address the issue of whether people who have previously had COVID, whether they should, the COVID infection, and are therefore antibody positive, like what Bill and Steve were presenting in the CARE study. These are folks that we've detected with natural infection. Should they still take the vaccine? This one's pretty much straightforward. Next slide. The answer is yes. Next slide. And why? There are 3 important reasons. Number 1, we do know that natural infection by COVID confers some degree of immunity. It's probably several months, but we just don't know how long it will last. Now that's true also of vaccines, but with vaccines, we can boost the response if we have to down the road. You don't want somebody having another COVID infection to keep boosting their immunity. It would be contradictory. We also know that people who have had COVID infection, although it is rare, they might have another episode of COVID, what's called a reinfection. Although it's rare, it's possible, and it may be more severe than the first time. It may also be less severe, but it can also be more severe. And then finally, Bill was talking about different types of antibodies. Bill and Steve were talking about different types of antibodies. We've got antibodies that detect natural infection, and then we have antibodies that detect if you've mounted a response following vaccination. And then we've got another set of antibody tests that we typically don't do commercially called neutralizing antibodies that can be done in both people who have had natural infection as well as people who have had the vaccine, which are called neutralizing antibodies. Those are the ones that really tell you if the antibodies that you have mounted are capable of blocking the virus. And so when we look at those levels, next slide, what we see is that people who have had infection before, they do mount these neutralizing antibodies against most of the variants that are circulating in the US. But compare the two, the infected folks as well as people who have had them in the past. Those are the antibody levels for different types of different variants of COVID vaccine. Compare them to the last group, which are vaccinated individuals. Without getting into a lot of detail, you'll see that clearly the antibody levels in the vaccinated folks are much higher than in either the acutely infected folks or the convalescent folks. And I say much higher. It may not look like a big difference on the graph, but this is a logarithmic scale. It's not a linear scale. So much higher levels of antibodies from vaccination, which probably correlates with a much higher level of protection from future infections, as well as a much longer lasting infection. A lot of this is still, we're still looking at it in a real-time basis, but that's where the evidence points now. And that's what those are the highlights of what I wanted to talk about. Next slide. And with that, I think that was my last slide, and wanted to thank everybody and turn it back over to Steve for the question and answer session. Thank you.
Great, thanks, George. That was really good. Appreciate you coming and doing that. We're going to do a Q&A, and as it Jessica, I think you're going to read the questions for us, and then George, Bill, and I will try to answer them. But before we get to that, I just remind you of just a few things, major points from this webinar. One, if you're not vaccinated, it's a good idea to get vaccinated. Two, it's a good idea for you to encourage the families of the children to get vaccinated. Once we have the older people and then the younger people vaccinated, then we're going to find some freedom that we have really seen for a long time. And then three, we would hope that you'll think about joining this study. So if you go to the UTHealth website, or if you Google the Texas Cares antibody study, you'll definitely find it. So that's all I want to say about that. Anyway, let's hear some questions. Jessica?
Hi, Dr. Kelder. This is Amelia. One question that came through is, could you talk about the transmission rate caused by fully vaccinated individuals? How likely is it for a fully vaccinated person to transmit the virus?
George, I think that's your ballpark.
That is, okay, and that is a wonderful question. It's also one of the questions that was central to the CDC opening up, loosening the masking restrictions last week. Up until now, although we knew that the vaccines were effective and safe, we did not know that if a fully vaccinated individual was exposed to somebody who was infected, that person would not get the infection, but they might harbor the virus and then pass it on to somebody else. I think that's what the question is addressing. Well, last week, the studies that, and they were very recent studies, one from Israel, two from the US, that the CDC relied on to opening up, in addition, examined this question, whether vaccination also protects others from a vaccinated person, should that vaccinated person be harboring the virus, even though they don't have the infection. And the data is increasingly convincing that yes, it does. May not prevent it in 100%. We've got the issue of the New York Yankees that we're looking at, and there was probably some transmission occurring there because they were all presumably vaccinated. But it is effective in general. The risk of transmitting to others if you're vaccinated is very, very low.
Are you still there, George, or do we miss you?
No, I'm here. I think I finished answering the question.
Oh, okay, sorry.
I hope I addressed it.
Okay, another question that came through is, if someone has had COVID, how long should they wait after having COVID to get the vaccine? Okay,
so in general, if you've had COVID, you should wait about 10 days. That's in general. There's one exception to that. And if for any reason you receive treatment for the COVID in the form of what's known as a monoclonal antibody, or even though we're not doing this much anymore, receiving convalescent plasma, then the recommendation is that you wait 3 months. Not because it's not safe to get the vaccine, but because both monoclonal antibodies and it was felt convalescent plasma confer immunity for about 90 days at least. And so this was they were reinforcing this, especially at the beginning of the vaccine, when vaccines were in short supply, and we wanted to give, you know, the people who had received monoclonal antibodies and were protected, wanted to have them wait before they got vaccinated, to give others a chance who were not as protected.
Okay,
Great.
the question is, what are your thoughts on the newest order from Governor Abbott prohibiting public schools from mandating masks or the COVID-19 vaccine, especially the younger children who are not eligible for the vaccine at the moment?
You know, that's a little tricky one to answer. You know, from my perspective, from an epidemiological perspective, I think kids should still be wearing masks, particularly if they're in that orange and red zone of community background. So I think you can relax a little bit if you're in the blue and the yellow. If you go back to those slides again, and if you look up your community rate, that'll help you make that decision. But clearly masks are a major effective preventive tool. So I think foregoing the mask is probably not the best idea that I've heard of. In terms of not requiring vaccine, you know, George just told you all about the safety data associated with it. So I do think if it were me, I would probably choose to have the kids vaccinated. But I don't know what all the rules and regulations are about how quickly it could happen. And I'm not aware of any other states just yet who are doing that. But you know, we're in a fluid situation. What we know today might be different tomorrow. You know, the CDC is going to announce in 2 weeks another re-examination of all the school rules, and now we'll have something different. So personally, I think I would send my kids to school with a mask, especially if they're 3 feet away from their friends. I would get them vaccinated. I think Texas wants to let the parents decide rather than the government and the school system.
I would only add to that, Steve, that, you know, requiring immunizations is not something new to COVID for school-aged children. And now I'm just expressing my personal opinion. It's too bad that we're politicizing what is a public health issue.
Okay, another question. At TPHA yesterday, Dr. Peter Holtz mentioned that as a region, the southern region of the United States has not done as well as Texas of the percent eligible vaccinated. He said this may be cause for concern during the summer months for some level of resurgence in the South. Thoughts on this?
Now, my major thought on that is that, you know, yay for Texas, we're finally looking good, or better than some of our fellow southern states. But, you know, it's not just southern states, it's the rest of the world that we have to think about. So if the other states are having a difficulty distributing the vaccine, maybe there's Texans that can help. And that's what I meant, that we all have to come together and act as a community. You know, in other countries with international travel or whatnot, I mean, that's where the new variants are going to come from, is from people continuing to be infected at higher and higher proportions. So that's what I think. George, I can see you have thoughts.
No, I was just agreeing with you. No, I agree completely.
I do think it points, this is Bill Cole, I do think it points to the continued need for surveillance and counting and local community transmission. You know, what happens, for example, in El Paso probably doesn't directly influence what happens in Dallas-Fort Worth, all travel notwithstanding. But making those decisions local, I think there is some benefit to doing that, and getting away from thinking state to state. The viruses don't know state lines. They don't know county and city lines either, and trying to manage where you can locally, whether it be your classroom, your family, your classroom, your school, your district, your city, I think it's a good way of doing it. Just counting things statewide, I think doesn't help emphasize the variation that we see across the state.
Okay, so we are.
Any more questions?
We probably have time for one more question, unless y'all want to answer a couple of more.
Are there lots of? I can't see the chat from my iPad here at Panera Bread. So how many are left?
Well, one that's easy, or hopefully it's easy to answer, is what about the research that finds that the masks are useless?
I am not familiar with research that finds them useless. The recommendations are to wear them and wear them properly, which means snug across the face and putting the nose underneath. George, you know anything about this?
So in research, there's a study to prove everybody's point, right? You're always going to find a study. I think we have to look at the weight of the evidence, and the weight of the evidence, even though there may be some studies, and you've got to really, this is what we do in epidemiology, right? We drill down and look at the specifics of each study, and there are often reasons for why they found what they found. It's got to be good science, et cetera. When you look at the good science and you understand what each type of facial covering and the differences among them, what they're designed to protect, you'll find that overwhelmingly the evidence supports that they are effective. Now, some are more effective than others. A cloth mask is less effective than an N95 or than other types of respirators, et cetera. So you've got to understand it. But the weight of the evidence, in my opinion, still strongly shows, and thanks to masking to a great extent, especially when we didn't have vaccines, masking, distancing really saved us. And it was bad,
another
but
point.
it could have been worse.
Another point that I thought of is that wearing a mask keeps when you sneeze and cough, it keeps it near your face. It's not going to get out and infect other people. So the mask offers protection that way by keeping you, if you have it, and a lot of people have it and they don't know, from spreading it. The mask also makes it harder for you to breathe it in. To my understanding, they're a little bit less effective in wearing the mask from keeping you to get COVID. They're more effective in keeping you from spreading it. That might be where that study came from. And that's why some people are now recommending wearing 2 masks, because that does a better job of blocking as you breathe in. Let's take one more question.
Yeah.
Or go ahead, George.
Yeah, I was just going to say, I think it also underscores the importance of letting the data guide the recommendations that are made. Just like Dr. Fauci, and I'm nowhere near his level, back in February of last year, I was one of the ones who was saying, to people on the street, there's no use and no sense in wearing masks. We needed those masks for healthcare workers. The evidence showed we were wrong, and we switched to recommending masking about 2 months later. I'm okay with that. I'm okay with that as long as you let the evidence guide the recommendations that you make. But I think, again, the weight of the evidence shows that they have been very effective at what they were intended to do.
Fair enough. That's a really good point. Let's do one more question, and let's answer that one. And for the remainder of the questions, George and Bill and I will get together and try and put some answers up online.
Okay.
So one more question.
Yeah, for the last question, we've actually received this question a few times, so it'll be a good one to end on. Will the vaccine prevent us from emerging variants, particularly the variant circulating in India right now?
All we can say is that right now, the main variants that are circulating in the United States appear to be susceptible to the vaccine. In other words, the vaccine is effective against the main variants that are circulating. Those main variants are right now, number 1 is the UK variant, and number 2 and 3 are some of the variants that were there before. The variant from India, 1.617, I think it's called, we need to keep an eye on. It has not penetrated a lot in the US. There have been some cases, but we need to keep an eye on that one because it's unclear why India had the huge surge that they had. There were certainly multiple factors, but this may have been one of them. But it's one thing for a variant to be more contagious, another thing is for it to be more deadly. I'm sure, the natural history of a virus is to mutate. It's going to try and defeat us all the time. And so the good thing is we know a lot about this virus, and the pharmaceutical companies are working already at preparing boosters or new forms of the vaccine to address variants. I think we need to be, we shouldn't lower our guard, but right now for the main variants in the US, the vaccines we have are effective.
Yep, and then that's another vote for getting the vaccinations, because it reduces the reservoir, the pool from which the virus can regenerate itself through mutations. But anyway, I want to thank you all for being here. We will send you a email from the registration page with a link to this presentation, so you can go back and look at it if you want to. In that link will also be an invitation to join the Texas CARE study. We really hope that you'll think about doing that. And if you have any further comments or questions, I guess you can email us back and we'll do our best. We'll probably be doing another webinar every couple months or so to try and keep up with these new findings and new recommendations. But anyway, from Panera Bread in Waco, Texas, thank you all. It was a great webinar. Appreciate it. Appreciate George and Bill too.
Thank you guys. It was a pleasure as always. Thanks everybody for inviting us.
Bye-bye.
Bye.